everybody. Thank you for having me. Today, I will be presenting on the antimicrobial stewardship antibiotic prescribing for positive urine cultures. The objectives for today's presentation are to distinguish between asymptomatic bacteriuria and a urinary tract infection, recall guideline recommendations regarding the treatment of asymptomatic bacteriuria, and select an antibiotic regimen using stewardship principles for UTIs. So first, I'll focus on asymptomatic bacteriuria, as it is one of our biggest stewardship opportunities when it comes to prescribing for positive urine cultures. So let's take a step back and talk about what is asymptomatic bacteriuria, or how I will likely call it ASB for short, and how common is it. So the definition is straightforward. It's basically bacteria growing in the urine, irrespective of any pyuria or white blood cells in the urine, in the absence of signs and symptoms attributable to a UTI. So many populations that frequently present to healthcare are known to have a high prevalence of ASB, and this table lists some of those populations here. So somebody with a long-term urinary catheter, a few days into having that catheter, it's 100% almost going to be colonized with that bacteria. For spinal cord injury patients as well, they have altered bladder function. And then just in general, elderly patients, particularly females, and those with diabetes are also have a higher prevalence of this. So how do we differentiate ASB versus a urinary tract infection? And why is that distinction important? Well, asymptomatic bacteriuria is the microbiological diagnosis. So it's bacteria in the urine is really all you need to make that diagnosis. And treatment is not recommended except for a select few populations. Now, UTI, on the other hand, identifying that bacteria certainly supports diagnosis, but we do need symptoms to make that accurate diagnosis of an infection. And treatment usually consists of a short course of antimicrobials, which I'll get into more later. So what do the guidelines say about asymptomatic bacteriuria? So there's many reputable national and international organizations that agree that screening and treatment of asymptomatic bacteriuria is not recommended unless that patient is pregnant or undergoing an invasive urologic procedure. Pyuria, or the high white blood cells in the urine, do indicate inflammation, but not necessarily infection. It's actually a poor marker for ruling in or ruling out true infection. So why is there such a strong consensus that we should not be treating asymptomatic bacteriuria? Well, there's been no benefit shown in multiple randomized controlled trials, and in fact, treatment may cause harm. There's some evidence that suggests that having asymptomatic bacteriuria may be protective. So one randomized controlled trial of young women that were treated for ASB actually had a subsequent higher risk of developing a true infection and a higher risk of getting an antibiotic-resistant bacteria growing. As far as adverse drug reactions to antibiotics, this is obviously a risk. It can range from mild GI upset to serious, potentially irreversible side effects, like tendon rupture with our fluoroquinolone class, for example. And we can't talk about ASB without talking about the consequences of C. difficile infection. So patients who are most likely to have positive urine cultures, like the elderly, are also at a higher risk for developing C. diff infection, usually due to their advanced age and other comorbidities, especially since many of the antibiotics we use for UTIs are considered broad and higher risk in general for C. diff. And then besides the clinical consequences, there's also economic considerations. So treatment is associated with longer length of stay. It's costly. It utilizes a lot of resources, that go into that urine sample collection and processing, drug costs, and that ultimately burden is shared by the patient, the health system, and third-party payers. So in terms of characterizing the mismanagement of ASB, who is at most risk for getting treatment for ASB that doesn't need it? This table is from an observational study of over 2,000 hospitalized patients with ASB. It found several risk factors. So they're divided here into lab specific and patient specific. For labs, we can see that patients with a positive urinalysis are almost 3 times more likely to get unnecessary antibiotics for their ASB. Similar findings for positive urine cultures and standalone leukocytosis as well. For patient characteristics, those with altermentation, incontinence, dementia, and increasing age were all risks to getting treatment for ASB. I think the most clear kind of takeaway from this is that urine testing really does drive treatment decisions. So once that test is ordered and it's abnormal, whether it's a UA or a urine culture, there's a high likelihood the patient will get antibiotics, regardless of symptoms. And because of this, the 2019 IDSA guidelines for ASB actually specifically call out this situation and state that older patients with a fall or confusion or delirium that are presenting and have a positive UA or urine culture, but no local urinary symptoms, no systemic signs of infection, those patients, it's recommended to assess other causes for their fall or confusion and observe off of antibiotic treatment in the meantime, since risks likely outweigh the benefit in this situation. So from all that we've discussed so far, it seems that we know that ASB treatment has no benefit in most populations, and we do know that there are harms with antibiotic use. So why are we still talking about this, right? So despite the mounting evidence we have on this, there's still a lot of common misconceptions that prevail in clinical practice and drive some of this. Some of these issues. So first off, bacteria in the urine equals a UTI. That is a misconception. I think I've mentioned this one already, but these are not synonymous. We need supporting symptoms or other evidence of UTI to make that diagnosis. For a positive urinalysis, is a good predictor of true infection. This is a misconception. In fact, there's a poor positive predictive value with findings like high white blood cells in the urine or leukocyte esterase. And that doesn't necessitate antibiotics. Cloudy or malodorous urine is indicative of a UTI. You may hear patients say this or family members say this. This doesn't correlate well with infection. It doesn't count per se as a symptom of a UTI. It usually indicates as dehydration. Falls and confusion in elderly are usually caused by UTI. So this is a big one, common reason for hospital admissions. There's many reasons besides a UTI for elderly to have falls and confusion, including dehydration, medication side effects, chronic diseases. And like I mentioned earlier, IDSA guidelines do specifically address the situation, saying we don't need to treat unless there are systemic signs of infection or specific symptoms. Next one, if we don't treat ASB, it will progress to a UTI. So this is not true. ASB has not been associated with long-term negative outcomes in the general population. And then the last one, urine cultures should be repeated after completing treatment for UTI. This is not recommended, in fact, and only increases our risk of finding an asymptomatic abnormality. Well, let's take a look at a patient case to paint a picture of a common scenario we see at the hospital here. This is something I might encounter during my daily and microbial stewardship work. So this is a 70-year-old female. She presents to the emergency department with hip pain after a fall at home. She's had a poor oral intake and was confused over the past few days. Her daughter says she has very bad smelling urine. She always gets like this when she has a UTI. For her findings in the ED, she has normal vitals, lab work, and imaging, except she does have an AKI and a high sodium level. Urinalysis is performed, and she has a 20 white blood cells per high power field and a large leukocyte esterase with positive nitrites. So she is diagnosed with a UTI and an AKI and started on ceftriaxone and fluids. A couple days into her stay, her urine culture results, and it is an E. coli with an ESBL positive test. You can see here it's resistant to many antibiotics. And one of those antibiotics that it's resistant to is ceftriaxone, which is what she was started on empirically. Sometimes myself or other pharmacists may get looped in at this point, especially if the patient has allergies, to see what kind of treatment we can do. So if we look at how she's doing clinically, over the past 2 days in the hospital, we find out that she's already improving before that urine culture came back. Really, the most likely explanation for her presentation was dehydration from her low oral intake. We saw the electrolyte abnormalities and renal function, and she responded to the fluids. So in her case, the E. coli should be deemed a colonizer and should not be treated. If we were to treat this, it would increase her risk of having an even more resistant organism down the line in the future. When she potentially could have a true infection, our options would be more limited. But you can see how it may be hard to ignore such a scary looking organism with lots of resistance once we have those results in front of us. So not ordering those urine studies to begin with may have been a better approach. The main takeaway from this whole section is symptom-free pee. We're going to let it be. Now, having the knowledge that we shouldn't be treating ASB is one thing, but communicating and articulating that to patients can be challenging. So patients and family members may not understand the nuances when it comes to when their urine requires an antibiotic or not. They may have been told conflicting information in the past. Sometimes we know inappropriate treatment is prevalent, so patients can certainly have confusion about that. So it is important to acknowledge this. We should not dismiss our patients' concerns, but there's some great resources available at AHRQ website here to help navigate some of these conversations. They have strategies or phrasing techniques that clinicians can use to improve their communication with the patient and maybe get the point across about the management. So here's an example of something that might be encountered. Somebody says, "My father is not himself today. His urine is dark and smells bad. Does he have a urinary tract infection?" This can be a great opportunity for you to educate them on the most common symptoms of a true UTI, including burning feeling when urinating, urge to urinate often. The dark urine alone is not enough to decide that he has an infection. His confusion without any other changes in vitals is not enough to diagnose that. He may be dehydrated. You may potentially get some resistance to this as well. It could also be helpful to point out that antibiotics are not all pure benefit. There is downside, there is risk and consequences from antibiotic use, and we should only use them when absolutely necessary. Now let's switch gears and talk about how to treat a patient that actually does have a UTI, whether that's cystitis or pyelonephritis. Antibiotic selection and duration of treatment depends on several factors. First one, I'll go over patient-specific factors, so things like allergies, drug-drug interactions, certainly past medical history, such as having C. diff infection, for example, are all relevant when making decisions about which antibiotics to choose. There's also microbiologic considerations for treatment of UTIs. It starts out empiric. We don't know exactly what organism we're treating. So we should be familiar with local resistance patterns of pathogens. This information can be found on your local antibiogram that's usually prepared by the microbiology department. There's usually different ones for outpatient versus inpatient organisms. So that would be helpful. Patient-specific information is also relevant. So recent urine culture results should be reviewed, but do be aware that the further out in the past that urine culture is that was positive, the less likely it is to be useful in predicting what is the current pathogen. There's no clear cutoff for this, but generally 90 days or so it is the time window. Anatomic location is one of the most important factors for both selection and duration of treatment. Certain antibiotics work great for cystitis, but should not be used for pyelonephritis. We can treat patients as having just a cystitis when they have just those local genitourinary symptoms. But if they have anything beyond that, indicating systemic infection like a fever, significant leukocytosis, this kind of suggests advanced infection and should be treated as pyelonephritis. And in pyelonephritis, of course, we have classic flank pain or CVA tenderness, usually accompanied by nausea and vomiting. And classic cystitis symptoms may be absent. The last thing here is complicating factors. These are things like retained kidney stones, tumors, catheters that are not removed. These can be an ongoing source of that infection and can make it difficult to clear, make patients more susceptible to recurrences and so forth. Pregnancy is another consideration. Antibiotics should be safe for mother and baby. And complications like renal abscess and prostatitis are advanced stages of UTIs and have different management strategies. So the hard thing about classifying UTIs is if you read the literature or guidelines, you'll find an impressive amount of different classification systems out there with no single accepted standard. So we can refer to UTIs as cystitis versus pyelonephritis. We'll see complicated versus uncomplicated, febrile, and the list goes on. So all this variability does make it challenging to implement the best recommendations. But the IDSA guidelines are actually in the process of being updated, and we should have more guidance on that, and the classifications should be more in line with clinical practice to guide treatment. For the purposes of this presentation, I will distinguish mainly by cystitis versus pyelonephritis. So before we talk about the antibiotics themselves, it is important to understand the fundamental principles of antimicrobial stewardship, which should always guide our decision-making when selecting a regimen. So major objectives are to improve clinical outcomes, minimize adverse events, reduce C. difficile infections, and antimicrobial resistance. And the way we achieve this is by using the right drug at the right dose, the right route for the right duration. And that's it, easy enough, right? Just use the right everything. So that's the only part we have left to figure out is what is that right combination? So first off, let's talk about nitrofurantoin. So one of the most important things to know is that it is an excellent drug for cystitis, but not for pyelonephritis. It does achieve high urinary concentrations, but not high enough tissue concentrations. So when infection has progressed to beyond the bladder, it should not be used. One of the great things about this drug is it has good activity against the most common UTI pathogens, but it's not necessarily so broad that it's a big driver of resistance. So it covers E. coli, Klebsiella, Enterococcus, Staph saprophyticus. It does not have coverage against Pseudomonas or some other enterics. For dosing, it's dosed as 100 milligrams BID for 5 days. It does not have any parenteral formulations. And for side effects, is very well tolerated. Some GI upset is always possible. And something to note about this drug is it's not recommended to use in patients who have a creatinine clearance of less than 30. So elderly folks, patients with renal impairment, may not have enough excretion of this drug into the urine, potentially leading to ineffective treatment. And this 30 mils per minute cutoff is recommended by the American Geriatric Society with their Beers criteria, a guidance for medication use in the elderly. This cutoff is more permissive than the package insert, which is 60 mils per minute. So this is what we use in practice. And last thing, C. difficile infection, as with most antibiotics, risk can be low, but never zero. So nitrofurantoin is considered low risk. Next, we have sulfa-methoxazole trimethoprim. I will refer to it as trimsulfa. This is good for both cystitis and pyelonephritis, has great oral bioavailability, and urine and tissue concentrations. It covers more gram-negative organisms than nitrofurantoin, but still does not cover Pseudomonas and also doesn't cover Enterococcus. Typical dosing, 1 DS tablet twice a day, and do that for 3 days for cystitis and 7 days for pyelonephritis. If we're treating outpatient for pyelonephritis, guidelines do recommend to give a one-time dose of an IV or an IM ceftriaxone or aminoglycoside like gentamicin, as this does help improve cure rates. For side effects, again, GI intolerance, photosensitivity can occur, rashes, some transient increases in serum creatinine are possible that don't necessarily always indicate a nephrotoxicity, and hyperkalemia is possible as well. For drug-drug interactions, warfarin is a notable one. So it does inhibit warfarin metabolism, and it can significantly increase the INR. It's not contraindicated together, but something to be aware of that may require more frequent INR check or an adjustment. And for C. diff risk, it is considered moderate. Next, we have fluoroquinolones, levofloxacin, and ciprofloxacin, which again, just like trimsulfa, can be used for cystitis and pyelonephritis. Their spectrum of activity is considered to be broad gram-negative activity, including against Pseudomonas. And in fact, fluoroquinolones are our only oral options when it comes to Pseudomonas treatment. So preserving their activity is very important. So we have convenient options for the patients who really need this. And then fluoroquinolones have variable coverage of enterococcidae. For dosing, this varies by agent a little bit, basically once daily for levofloxacin, twice daily for ciprofloxacin. We do 3 days for cystitis and 5 to 7 days for pyelonephritis. And again, that same recommendation for outpatient treatment where we do want to give them a one-time parenteral dose before the oral course. For drug-drug interactions, divalent cations, so antacids with calcium, magnesium, or multivitamins should be separated by about 2 hours for best absorption. Warfarin, again, can interact and INR can be increased, but it's not quite as dramatic as with trimsulfa. And then ciprofloxacin and tizanidine are contraindicated in the package insert as this can cause hypotension and excessive sedation. One of the most important things to know about fluoroquinolones is that they are associated with unique risks that other antibiotics are not. So serious and potentially permanent side effects, such as tendon rupture, peripheral neuropathy, CNS effects, aortic aneurysm dissection, myasthenia gravis exacerbation, and others. So that's just a list of all the things that have been associated with this class. So in addition to those risks, they are known to drive resistance. So not just resistance of those fluoroquinolone resistant strains, but also other resistant strains such as MRSA and ESBL. And to put the cherry on top, fluoroquinolones are one of the highest risk antibiotics for C. difficile. So all this has led the FDA to come out with safety communications over the years, adding boxed warnings to the labeling for serious reactions. Over the decade, it seems like every couple years, they were coming out with more and more adverse events being added to the labeling. And they also added a statement that warns that risk is generally outweighing the benefit in patients with uncomplicated infections like UTIs, bronchitis, or sinusitis, and that fluoroquinolones should be used only when there's no other alternatives. And this is, in fact, FDA made this official statement. This is remarkable because the agency does not usually come out and say this for really any other antibiotics. So with that, let's talk about beta-lactams. Beta-lactams are much friendlier in their safety profile than quinolones. This is a very large class of antibiotics. They have different properties, but there are some similarities as a group. So as a general rule of thumb, they're effective for both cystitis and pyelonephritis, but there is some variability in urine and tissue penetration depending on the agent. Similar variation in spectrum of activity. For example, amoxicillin clavulanate and some of the later generation cephalosporins like ceftriaxone, cefdinir have good empiric activity against uropathogens. Notably, cephalosporins do not have activity against enterococci. So enterococcus UTIs will not be treated by things like ceftriaxone or cephalexin. Penicillins and amoxicillins will have activity against that. Something worth noting is that cefazolin susceptibility can actually be used to predict susceptibility to oral cephalosporins. So on a microbiology report, you may not explicitly see those oral cephalosporins listed, like cephalexin or cefdinir or cefaclor, but cefazolin can be used as a surrogate for those in its place. For dosing, typically we do 3 to 5 days for cystitis and 7 days for pyelonephritis. And again, with empiric treatment outpatient, it is recommended to give a one-time parenteral dose. For side effects, beta-lactams are very well tolerated, GI upset is possible again, and for C. diff risk, this generally increases with spectrum. So penicillins are the lowest risk, but that increases when we add the beta-lactamase inhibitor, such as with amoxiclav. Also, some of the earlier generation cephalosporins are considered moderate risk. And then the highest risk is with the later generations like ceftriaxone, cefdinir, as well as other beta-lactams like carbapenems. Now, something that you may have come across before is this notion that oral beta-lactams are just not as good as other options for UTIs. Now, this stems from the IDSA guidelines, the most recent being in 2010, which was a while ago. It does state that oral beta-lactams are not first-line agents due to inferior efficacy and more adverse events. Now, this recommendation is based on older studies that do have significant limitations. Those studies are very variable and heterogeneous with different regimens used and different comparators. They had limited sample size, and some of them had very suboptimal dosing and different outcomes definitions. And as I mentioned before, beta-lactams are a very large class of antibiotics that do differ from one another. So really kind of lumping them into this one statement is an overgeneralization. And since then, since those guidelines, we have new research that actually shows oral beta-lactams have comparable efficacy, even for severe infections. In fact, in 2021, the consensus guidance for uncomplicated gram-negative bacteremia said that oral beta-lactam regimens with optimal dosing are acceptable alternatives to fluoroquinolones or trimsulfa, and they recommended a 7-day course. There's a notable VA study that was published in JAMA in 2020. About 4,000 patients were included with bacteremic UTIs. It was mostly elderly men, since this was the VA. And compared to those who got fluoroquinolone or trimsulfa versus oral beta-lactams as a step down, they found no difference in the primary outcome being recurrence and 30-day mortality. So with that being said, it's very important to recognize that not all oral beta-lactams are created equal, especially in terms of bioavailability. So cephalexin is very good at over 90%, much like our fluoroquinolones and trimsulfa. Amoxicillin and penicillin are a bit lower in the medium category, and the rest are considered low. Now, good bioavailability is only half the picture, because what we're really aiming to do is optimize the pharmacokinetics and pharmacodynamics. We don't need 100% bioavailability. We need just enough drug at the site of infection to kill the organism, whether that's in the urine or the tissue. So just because bioavailability is considered low in relation to another antibiotic doesn't mean that it's not enough to treat a simple cystitis. For example, or for treating a pyelonephritis, we may be able to overcome that low bioavailability by maximizing the dose and getting enough good tissue concentrations. So don't count these out, these beta-lactams with the lower bioavailability. So for example, we can give amoxicillin at high dose of 1 gram 3 times a day for pyelonephritis to kind of compensate for that lower bioavailability. And they are very well tolerated even at higher doses. Next antibiotic we have is fosfomycin. So this is only indicated in the treatment of cystitis and not pyelonephritis. And it does have high urine concentrations, but only about 37% oral bioavailability, which does lead to suboptimal tissue penetration. For spectrum of activity, it covers E. coli, Klebsiella, Proteus, and Enterococcus well. It does not have Pseudomonas coverage. Notably, it does retain activity against even resistant organisms like ESBLs. So it's a great option for cystitis, where there's a lot of drug resistance, potentially precluding other options. For dosing, it's available as a packet of powder. Patient can mix it with water and drink it, and this is a one-time dose. There's no IV or IM formulations in the US. There is overseas an IV formulation, but it was unfortunately not approved here. As far as side effects, it's well tolerated. GI upset is possible, and it has a low C. diff risk. The catch with fosfomycin is it can be pricey, up to $100 out of pocket for just that single dose, and insurances may not cover it. So that is a consideration. So the final class of antibiotics that I'll touch on is aminoglycosides. So gentamicin, tobramycin, and amikacin. These are effective for both cystitis and pyelonephritis. We get very high urine concentrations after just a single dose. And this can provide coverage for several days after that single dose. And they have good tissue penetration. For spectrum of activity, they are considered to have broad gram-negative activity, including Pseudomonas and many of the enterics. For Pseudomonas, we should only be using tobramycin and amikacin, and not gentamicin. For activity against gram-positives, it does not cover gram-positives, so Enterococcus or staph will not be covered. So as I mentioned, just a one-time dose, for example, gentamicin 5 mg per kg, is enough to treat a cystitis. This is a great option for patients that have resistant isolates that may otherwise have been sent to the hospital for IV antibiotics. Giving them that one-time dose of gentamicin in the office can really prevent hospital admissions when really the only reason for admission is IV antibiotics. For pyelonephritis, treatment usually involves, again, just a one-time dose followed by an oral regimen. But if it needs to be continued, it's generally, again, for 7 days and is dosed daily or less frequently based on renal function and drug levels. Now, the Achilles heel of aminoglycosides, they don't have an oral option. So again, just IV or intramuscular for these. For side effects, renal impairment and ototoxicity, so hearing issues, are known side effects of aminoglycosides, but these are not instant effects after a single dose. The risk is cumulative. It increases with duration of therapy, and with the short durations we use for UTIs, the overall risk of serious side effects is very low. Another advantage of aminoglycosides, they are considered to have relatively moderate risk for C. diff. The part of selecting a good antibiotic regimen is choosing the right duration for that antibiotic, since that is one of our stewardship principles. So as I mentioned, the most widely accepted durations for each antibiotic on the previous slides, I wanted to reiterate that longer durations are not better. So traditionally, guidelines recommended even up to 14 days for pyelonephritis for some antibiotics, even for uncomplicated cases like women with UTIs without comorbidities. But several randomized control trials have shown that 7 days is enough for most patients, even with uncomplicated gram-negative bacteremia. So the trials listed here on the slide all compared 7 versus 14 days for gram-negative bacteremia. They excluded patients with complications like abscesses. Patients had to be stable for 1 or 2 days before stopping antibiotics. And the source of their bacteremia was majority urinary, with some intra-abdominal and others as well. And no differences were identified in clinical outcomes such as mortality or relapse at 30 or 90 days. So there are, of course, exceptions, and some patients may need longer antibiotics. But first, let's address some populations that do not need longer antibiotics. So males and patients with diabetes have traditionally been referred to as complicated, even if they develop a UTI, which has led to use of longer courses for them. But again, we have new evidence to suggest otherwise. So a randomized control trial in 2021 showed that 7 days was again not inferior to 14 days, even in this population. They studied men with febrile UTIs, so not just cystitis, but more progressed infection, and 40% of those men had diabetes. We should certainly recognize that men are indeed unique. They don't usually get UTIs nearly as often as women. And the fact that they do have a UTI should prompt for some careful diagnostic workup for any anatomic abnormalities and excluding more serious infections like prostatitis. But outside of this, there is nothing to indicate the UTI should be treated differently than in females. In terms of diabetes, of course, poor glucose control can certainly increase the risk of developing a UTI and recurrent infections. But again, we do not need different antibiotic regimens or durations simply based on this. So the scenarios that do warrant longer antibiotic courses at this time are limited to patients with urologic abnormalities. So patients with retained infected kidney stones, for example, they're going to have that ongoing nidus of infection. They may get a stent placed, and that stone remains there for weeks afterwards until it's removed. So these patients generally do require longer, such as 10 to 14 days of treatment, but there's no high quality data for this population specifically. Similarly, for catheterized patients, if we don't remove the catheter, longer treatment may be used again. So now let's wrap up by reviewing a case and practice applying some of these stewardship principles. So MJ is a 34-year-old woman. She presents to her primary care provider with new symptoms of dysuria, nausea. She doesn't have vomiting, but she does have some fatigue. Her past medical history includes diabetes and anxiety. She doesn't have any allergies or recent healthcare visits. Her vitals are normal, without any abnormalities, and her physical exam does reveal left CVA tenderness. So she is diagnosed with pyelonephritis and urine cultures are ordered. So what is the most optimal treatment for her? I will just read through these answers and you can think about which one you would choose. Is it A, nitrofurantoin 100 milligrams twice daily for 5 days, cephalexin 500 twice daily for 7 days, C, ceftriaxone times 1, followed by trimsulfa 1 DS tablet twice daily for 6 days, or D, ceftriaxone followed by levofloxacin daily for 10 days. So the most optimal answer is C. For empiric treatment, it is recommended to give a one-time dose, again, of that ceftriaxone or aminoglycoside. So you could use gentamicin here instead. And then continue with trimsulfa for a total of 7 days. A would be incorrect because nitrofurantoin should only be used for cystitis and not pyelonephritis since it doesn't have good tissue penetration. For B, cephalexin, it's not optimally dosed here. So this 500 milligrams BID dose may be okay for cystitis, but ideally should be higher for pyelonephritis, such as 1 gram 3 times or even 4 times daily. And then D is not the best option because fluoroquinolones do have those serious risks that are not present with other antibiotics, and we should only use them if there are no other alternatives. Also, 10 days is too long for this uncomplicated pyelonephritis. So now it's been a couple days. Her urine culture comes back, and these are the results. She's growing E. coli with a susceptibility profile shown here. We see amoxiclav and ampicillin sulbactam are resistant, and so is the trim sulfa, which is what we empirically started for her. So you give her a call, and she says she is still having some dysuria, but no other changes, no fevers, or anything like that. So what do you think the best option is now? Should we do A, nitrofurantoin, 100 milligrams BID? Should we switch her to B, cephalexin, 1,000 milligrams 4 times a day? C, ceftonir, 300 milligrams twice daily? Or D, levofloxacin, 750 daily? So the best answer would be B, cephalexin. The isolate is susceptible to cefazolin, so we can use high-dose cephalexin to complete treatment, extrapolating from that cefazolin susceptibility. Cephalexin is optimally dosed here. This is a high dose that will work well for pyelonephritis. For A, again, nitrofurantoin should only be used for cystitis. B, ceftonir is not optimal because it is a third-generation cephalosporin. It has unnecessarily broad gram-negative spectrum. And in fact, it also has about 25% bioavailability, even at maximum dose, which may result in suboptimal treatment. And for D, levofloxacin, again, is susceptible, but unnecessarily high risk and also very broad for this organism. So it should be reserved if we can't use other options. So the last thing I wanted to do is point you to some great local resources for antimicrobial stewardship. So CASIC is Kentucky Antimicrobial Stewardship Innovation Consortium. This organization is led by our very own experts in stewardship here at Norton Healthcare. The purpose of CASIC is really to improve antibiotic use in the whole state of Kentucky. I encourage you all to scan the QR code, go to the website, just check it out. There's some excellent educational resources. We have very popular clinical educational pearls that give you just bite-sized pieces of information about certain relevant topics in stewardship. We also have quick patient education cases that we pull on social media, as well as grand rounds that are recorded, newsletters, and many more things. So that concludes my presentation. Thank you all for joining. At this time, I welcome any questions or discussion.
Thank you so much, Elena. Are there questions that participants have today? If so, please put them in the Q&A section. That was a lot of great information. For providers who might be having a hard time discerning what antibiotic to use, can you speak a little bit about opportunities to collaborate with clinical pharmacists across Norton Healthcare and how we might tap into that resource routinely?
Yeah, certainly. So at Norton Healthcare, we're really lucky on the inpatient side to have so much support from infectious diseases pharmacists. There's one of me at least one of me at every campus in the hospital. Norton downtown and Audubon have 2 ID pharmacists as well. We have an on-call service where our number is 629 MRSA. Kind of easy to remember. You can just dial that number, and if you have a question, somebody's going to always answer and provide any guidance, whether that's on, like a very resistant organism or just talking through patients. We do that routinely. So certainly reaching out to us would be the best thing. Yeah.
Thanks. Any questions about the great information you heard Elena present today? Okay. If not, I just want to remind everyone that you'll receive an evaluation for credit. In addition to the email when you exit this webinar, you'll see a link to the SurveyMonkey. select continue, and the button will move towards the evaluation credit. I really would love for everyone to join us for our next pharmacology live stream on August 22nd at noon. The session will focus on GLP-1s and obesity. Thank you for being here, and I hope everyone has a great week. Thank you most especially to Elena for sharing your expertise with us today. This was fantastic.
Thank you so much.